people are moving around. And it's now not just a regional problem, but it's actually a public health crisis, and everybody needs to know about it.
And you mentioned the regions here. Then are there, contributory factors? And if you can break down those specific factors that lead to this.
Yeah, that's a good question. So when you talk about regions, it goes back to the genetics of the disease. So remember, we've talked about a mutation that's affecting the beta chain. Now, this mutation came about as a way of conferring survival against severe malaria. So, and that's where you find it within the malaria endemic regions. So first of all, the cell that has got the sickle cell is usually hostile to the malaria parasite. It's destroyed very quickly within the spleen, and then also it doesn't have certain receptors that allow the parasite to come in, and that's why it's seen along these regions to confer survival. But then it only offers advantage to people who have a trait. So trait basically means that you have only one chromosome that is affected and another one is normal. So people who have sickle cell disease still have the severe form of the disease, and that's why we then have this accumulation around the malaria endemic areas.
And in terms of the prevalence, before we come to the specific numbers, which age group is the most in terms of susceptibility?
Right. So remember, this is a condition that you are born with because it is genetic, meaning your mother has a defect and your father, so both of your parents are trait, and then it is passed down to you. Now, when you're a fetus, the kind of hemoglobin you have is called a fetal hemoglobin. And this does not have the beta chain. So when you're in utero, you're in the uterus, you're not at risk because you don't have that chain. But as you begin to mature, the body switches off the production of fetal hemoglobin and now gives you the adult hemoglobin. So you begin getting susceptible as you move towards the adult hemoglobin. But back to your question, under 5s are really at risk because at this particular point, nobody is thinking about sickle cell with these children. Because remember, when they were born, they were very normal. So usually these are the children who would die because of infections. They will die because of certain organ complications. So we talk about it, and that's why we bring the issue of newborn screening, because under 5s are really at risk of mortality during this.
And let me call it this marriage screening then, because you have pointed out genetics here. Is it advisable then that you can go for genetic counseling?
Absolutely, and it's one of the things that we talk about when you're talking about the prevention of the disease. Now, there are regions, including the West Africa, which carry the burden of the disease, including Nigeria, where you find some pastors telling couples to come with the sickle cell test before they get married. Now, usually it's a touchy topic because when people are in love, it's very difficult to tell them, now you cannot marry.
It's a whole different ballgame.
You are having a trait and you might give birth to a child that has sickle cell, but it is important for them to have this information. So I would totally agree with you. It should go as to part of premarital testing.
And I'm looking at the statistics, and it's startling. 14,000 births annually of a sickle cell disease in Kenya. Does this point to the direction of public health crisis?
Absolutely. Remember, so from a global perspective, you're talking about 500,000 people born with sickle cell disease every year. And sub-Saharan Africa is taking the bulk of it because 3/4 of those people are here with us. And then, of course, Kenya giving its contribution to 14,000. So it's a global health, it's a public health crisis, because then you're talking about 14,000 people who are at risk of dying if nothing is done to them. So indeed, it's a public health issue.
And then what are the remedial measures then here of these numbers, and in terms of both state and non-state actors cooperating to specifically address the 14,000, a number that I'm sure even as professionals really keeps you awake at night?
Absolutely. Now, one of the things that would strongly support and has been shown to support even in different settings is what we call newborn screening. So usually we would screen, currently there are different partners who are doing pilots in the endemic areas. Yeah. But we need to get to a point where we have agreed that migration is taking place, and therefore we need to make it a national policy as part of antenatal care and newborn care, that we should screen for sickle cell disease. And the importance of that is, far as much as this neonate might not show symptoms, the moment you realize they have sickle cell anemia, then you are able to incorporate them into care as quickly as possible, and then brings out the question you're talking about, multi-sectoral cooperation. So you have the government giving this policy, you have healthcare workers on standby to do this screening, but you also have pharmaceutical companies that come down to also negotiate how can we bring down the cost of things like hydroxyurea, which is currently not accessible to everyone. How can we make vaccines accessible to everyone? How can we make antibiotics that are very crucial, especially for under 5, and even going back to clinical trials, because there are exciting clinical trials that are happening in the world right now. How do we bring them home so that even our patients can benefit?
And of that number, Dr. Rebecca, if you may expound, what are the survival cases here of children who then make up to the age of 5 years and beyond?
Now, the truth is, we might not give the number to the digit, but most of these patients will not make it to their 5th birthday if they are not incorporated to care. So we are talking about almost 70% of the patients that we've talked about who will not make it to their 5th.
And we open, of course, the SMS lines for our viewers. The SMS code is 22422. If you may have a specific question or an explanation that you may require from the doctor here, then we can put that up for the response from the doctor here, so that she can as well respond to some of the questions that you may have and the and explanations and queries that you may seek. And Dr. this brings me to the question of then the observable signs that a parent here may want to observe, and then which leads up to the clinical visits that you have recommended here. What are the very signs that someone should look for?
So we normally talk about what is called the natural history of the disease, meaning that it might manifest differently depending on the stage or the age of the patient. But one of the things that you'd see is, especially when they're in their infancy, this is a patient who will present with a lot of pain. And the pain that we get is what we call dactylitis, which is inflammation of fingers and toes. And remember, we had talked about occlusion of vessels that occur, and they could occur even in small bones. So these are children who come with very swollen fingers, very swollen toes. The other thing is that there's an organ that we call the spleen that is usually enlarged during this period of infancy, and they are in and out of hospital because of infections as well as anemia. Now, based on the kind of breakdown of red cells that occurs in this body, there is usually what we call some toxic waste that are released, including bilirubins, that usually coat the eyes. So these patients usually have a yellow tinge in their eyes. So that's what we call jaundice. And remember, the bone marrow, that is usually what is like the factory of the of blood cells, is on overdrive because we are breaking so many cells. We are trying to replenish them. So every bone marrow is incorporated to this process, including the one in the skull. So these patients usually have a form of bossing that occurs in the skull. But it's important for the viewers to understand that sickle cell disease is a multi-systemic disease. So every organ can be affected. So they can have issues with the eye, what we call sickle cell retinopathy. It can cause a stroke. And usually, in fact, when you find a child having a stroke in their young ages, you should rule out sickle cell disease. You could have sickling occurring in the chest, and that's what we call acute chest syndrome, and it's a leading cause of mortality for these patients. It could affect bone, their growth and development, so they tend to look a bit smaller or even delayed in terms of growth compared to their normal counterparts. But kidneys can also be affected. So it's a multi-systemic condition that should then call upon a multidisciplinary kind of management.
Which may in turn affect the internal organs as well.
Absolutely.
So we talked about 120 days earlier, the normal days. So 20 is the number of days, that's minus 100. So which, as you have said, then brings out the aspect of overdrive for the production of more red blood cells to sustain the blood flow. However, how then can this at that point be medically attended to? What are the remedial measures at that particular point when the patient is on the hospital bed?
Right, so one of the things that usually happens, so you're talking about an inpatient scenario. Blood transfusion is extremely important in the care of patients with sickle cell disease. Now, we already know that they are running an anemic state, so they usually have what is called a baseline hemoglobin. The moment they drop about 2 grams below that baseline, they begin to even give you symptoms of anemia. So these are patients who should be transfused. But when we talk about transfusion in sickle cell, it's not just the simple top-up transfusion that you get. There's even role for what we call exchange transfusion, meaning you bleed out the patient and give them fresh blood that does not have the sickle, that does not have sickle cell. So it's a lot to do with transfusion, but over and above that, there's the role of hydroxyurea. You've probably heard of it, which is a drug that has been shown to change certain properties within the red cell, including reverting it back to the fetal state, so increasing the levels of fetal hemoglobin that don't sickle and changing membrane properties so that it doesn't stick to one another.
Okay, then let's come to the major part of it, accessibility. For the number we have talked about here, certainly they need medical attention. Talk to us about accessibility, affordability in light of a drive in our country towards universal healthcare coverage. Are these patients getting the deserved medical attention? Or can they get that medical attention?
Well, can they? They can, and they should. Are they? Is not all of them. Now, when you talk about care, it has got to be accessible, and accessible has to be, there's a healthcare facility that can screen. There's a healthcare facility that can make the diagnosis, confirm the diagnosis. And these are not available everywhere. Remember, we are saying because they are concentrated in certain belts, then it looks like there's a particular part of the country that is left without this kind of care. The other thing is access to hydroxyurea, which is currently what we are using for the management of sickle cell disease. Now, in terms of cost, it might be a bit out of reach for a number of our patients, because there are times the tablets could go as high as 80 shillings, 50 shillings. I know there are discussions to bring it down to even 20, but still not many people are able to access in terms of cost. And also, apart from just giving them this, there's the aspect of having facilities that can screen for organ complications. Remember, we've said it's a multi-systemic disease, so you need to have a facility that can screen for organ complications, screen for the risk of a stroke, screen for the risk of a renal complication. So in terms of accessibility, the care tends to be concentrated in certain centers or certain facilities, but many others are still left without this care.
And given that a majority of Kenyans can only access public health institutions, is that a cause for worry? So the thing that we might need to do is then to support these
health institutions to be able to take care of these patients. I know currently with the SHA package, there's something that is being, given to patients who have sickle cell disease, including diagnosis at household level, diagnosis of patients, outpatient services, including treatment, lab services, inpatient services. But remember, we are giving capitation and saying per household, per person per household. But we have homes that have 3 or 4 patients with sickle cell. So it becomes a bit difficult to support those kind of patients. So public institutions should be supported by healthcare capacity building for healthcare workers, diagnostic support, treatment, and then also now coming back to give a national health cover that supports these patients. Okay,
and let's talk about, before we come back home and proceed with the treatment part, the recent groundbreaking development, the first CRI SPR-based gene therapy, and looking at then how this helps to provide explanation here on in itself, this coming as an antidote to the problem that we have talked about and discussed here, and whether the policy framework in our country can easily absorb this, and whether we are ready even to go that way.
So first is to try and break it down. What is this technology? So this is Casgevy's it's gene therapy. And basically what gene therapy does, it tries to address the problem from the root. So we basically take out patient cells that have this mutation and genetically reprogram them within the lab. Okay. So we give them a component that goes to the gene that usually switches off fetal hemoglobin production. And we manipulate that gene so that the body does not produce adult hemoglobin that has the problem. So constantly, the patient then produces fetal hemoglobin, and that is what gives them a form of cure. The question on whether it is accessible currently, the cost of gene therapy is about $2 million per patient.
The cost per patient
is about $2 million. Now, that is, of course, out of reach for most of our patients. And apart from just giving gene therapy, there's the aspect of providing infrastructural support within the country that can support that kind of therapy. Now, that is very expensive. It needs a lot of multisectoral collaboration. So while we would want our patients to get this kind of care that is already happening in the West, I would probably suggest that a priority would be to support the availability of what is standard of care in our country for everybody first. And then think about advanced therapy for patients who cannot benefit from hydroxyurea.
That's exorbitantly expensive. Roughly comes to about 260 million Kenya shillings. And is that technology here?
No, that technology is not here.
Okay, but in the short term then, what can be its, if not the perfect replacement, at least a substitute to give permanent cure for people with sickle cell disease?
So the other modality that also promises cure or some sort is transplant, but then again not very well accessible in our country as well. But be that as it may, I still insist that supporting newborn screening, incorporating patients to care, giving them hydroxyurea, folic acid, vaccinations, properly transitioning these patients from pediatric to adult care could still support these patients even as we wait for gene therapy to be available or transplant services to be available in the country.
Yeah, and so that then brings us to the question about the individual families and households that are affected, given the number that you have mentioned of the 14,000. So how is the campaign and the awareness around it, given that you have talked about the symptoms that we should be looking out for? How is the campaign around it and the sensitization for them to understand and get a way or a formula of living with people with sickle cell disease?
So first of all, there has to be a lot of correct information to the public, because there's currently a number of myths and misconceptions that are associated with this disease that go on to actually affect whether these patients access care. So there are different partners that are working in this sector, trying to even use community health volunteers to try and explain what the disease is. But there's still a lot that can be done in terms of raising awareness within the community, even amongst healthcare providers, because there are certain healthcare providers who have not managed a patient with sickle cell disease based on where they are at geographically. So the awareness needs to be broad. There is some work that is currently happening, but we need to amplify this work.
And how key is the involvement of the universal healthcare providers, those who have been tasked and are in close proximity with people in their households and in the villages, and number two, the caregivers at home, because home treatment is also now an encouraged mode of allowing people to recuperate well.
So starting with community health volunteers or community health extension workers, teaching them the salient features of sickle cell. You see, you're in a community, you see a child with jaundice. Can you be able to link them up to care? So breaking this disease down in a very simplified way that people in that community health workers can understand is something that the government should be thinking about in terms of raising awareness. But even at household level, remember this patient comes to the hospital for drugs and for care. The healthcare worker needs to build capacity in this mother or this father who's taking care of this child. Things like dehydration could trigger an event or a crisis. Things like deoxygenation, so people who go mountain hiking, scuba diving, for example. Infections, being able to feel and see, oh, I think my child has a fever, so giving an antibiotic at home as you rush your patient to the hospital. Another very unspoken complication of sickle cell disease is something we call priapism, which is usually not very spoken about, which is very sustained, very painful erection that occurs amongst patients because of the sickling process. Now, the problem with this is that if it is not addressed, this child could have erectile dysfunction in the future. But there's a lot that the mother can do at home. They can hydrate them, cause them to walk, check and see whether it reverts and takes them to hospital. Palpating for a spleen, you know, there's just a hard mass on the left side. The mother can be taught to do that. And if they see the child is sick and that spleen is enlarged, then they could rush to hospital. So a lot of training can happen at the healthcare level.
And that then, which then means the institution of parenting here has to bear a lot in terms of close observation, close proximity, and watching around for the signs that you have talked about. How much of it has contributed to lessening these cases here? And then with clear reportage mechanism, the new professionals can chip in. Has this been of help, this close attention, especially at the parenting level?
Very much. I mean, in clinics, we see patients come and they even have records of the hemoglobins that their children have, and they tell you, Daktari, my child had a HB of 9 3 months ago, 8 last month, today we are at 6, and they write them down. There are people who would even come and tell you, Daktari, I'm here, I'm not sure what's wrong with the patient, but I just think that my child has a fever. And when you investigate, you find that this child actually has a serious infection. There are moments where the parent will come and tell you, I think my child is limping. This is not how they walk. And then you go back and find that this child has a stroke. So talking to parents, and you know, there's usually this joke that it takes a village to raise a child. But we don't see it happening in sickle cell, where the village is not coming in to support the parents. But very educated parents can make a difference in terms of the life of the patient.
And because if within the community setup is where these challenges that normally are very evident, how is stigmatization a key contributory factor here in the sidelining or in ostracizing people with sickle cell, given that a large percentage of that are children?
So you raise a very important view, because one, stigma happens at multiple levels. So stigma happens at the household level, because failing to understand the genetics of the disease has made certain women lose their families, because there are people who believe this woman has been married in this community and all her children are dying. Now, we have talked about the fact that for you to have a patient with sickle cell disease, the father has got to have the trait, the mother has got to have the trait. But you find that there are women who are told that you have the problem, and therefore we need to marry another woman, not you. And then they also marry another one, and they realize that the other family also has sickle cell. The other thing is, even at community level, I've had patients who've told me that people have said that I'm into witchcraft, or people have said I'm into devil worshipping, because remember, your blood levels are going down. So there's a Swahili saying, wananyonya mtoto damu, you know. There are people who have believed it's a curse. So there are families that have been told this family is cursed, we cannot help them. But even at employment level, you know, you find that this is a patient who might be in and out of hospital. So there are employers who have refused to employ.
See, they're more of a burden.
Yes, because I'm not sure whether you'll turn up to do this interview with somebody tomorrow. So do I really want you to be here? And they have, and this kind of stigma, even in schools, you find that their boarding schools will say, no, we are not going to admit that child here because they are in and out of hospital. They might die here. So the stigma that is multi-level.
Multi-layered. And then mentioning those two critical levels at the homestead society level and at the work level, are there then specific tasks that these individuals cannot undertake or can undertake given their condition?
Now, usually patients who are well cared for are patients who can live normal lives or near normal as possible. So there might be just issues that we know that can precipitate a crisis. For example, extreme exertion, you know, things to, so you want to make sure that you're giving them an opportunity to work, that probably they're not extremely exerting themselves, which could precipitate a crisis. If they are working maybe in a place where they are prone to infections, maybe you don't want them to work there because infections for them could precipitate events. But as much as possible, when they are taken care of, they should be able to perform tasks that other people can perform.
Living a normal life.
That is what we want. Yeah,
and the day is tomorrow, the 19th. Is this part of the campaign that you'll carry forward, given its significance of the relevance and the importance, the contributions that can be made by people with sickle cell and their value and their output if well taken care of? Is this a message that you are taking forward when you will be commemorating the day tomorrow?
Absolutely. This is a message that we're going to be taking forward, and we are not just taking it forward to the patients, but all stakeholders that are involved in the management of patients with sickle cell disease. And just to tell our viewers that some of our facilities, including our Equity Afia facilities, do have care for do have support in terms of screening and diagnostics for patients who have sickle cell. So if you are around an Equity Afia facility, please drop by if you need a sickle cell assessment. And apart from that, you're then going to be linked up to care.
Kenya has made so many strides in so many areas, especially in funding for critical illnesses. And certainly, how much of this, given the dispensation that we are in, it speaks to the policy, the funding needed, and the care itself to explore. I mean, we talked about the expensive nature of the treatment, but what is it that we can devise? And COVID taught us lesson of coming up with our own ways of handling crisis at our own level. What is it we can do within our infrastructure system, the funding needed, and the retooling of our professionals as well, and the institutions of healthcare?
So first of all, and that's a very good question. First of all, we need to look at this condition as, look at a multisectoral approach in managing sickle cell disease. So first of all, we need to ensure that newborn screening goes on to the care, antenatal care for patients for everybody in the country, because we have already seen that we are contributing a huge number. So if a mother goes to deliver today in a public or a private facility, it should be made mandatory for her to get newborn screening for that child. That's number one. The second thing is to be able to have a cover that can support screening, treatment, so that, again, you want to shield families from this economic burden that comes with the disease. You want to be able to start thinking also of advanced therapies for sickle cell disease, and this goes to capacity building. So you want to start sending some of your healthcare providers to areas that they can learn about transplants, because apart from just having transplant services in the country, we are having patients who are going out of the country for transplants. So you need to be able to have a healthcare workforce that can do follow-up even for that patient, because they will go to India. If they have a complication, they'll not go to India, they'll have to come back. I mean, they will have to be seen around the system. So is the system able to see those kind of patients? And apart from that, we need to then begin to think about even creatively, like we've talked about countries like West Africa that are now telling couples who are coming to
do genetic cancer.
Yes, I mean, it's a touchy topic, but we have seen it working even in other countries. So I think those kind of things can be made available in our country, even as we look towards.
So many questions. Earlier we talked about the question of replenishing the blood because of the rate at which of the 20 we talked about days instead of 120. And in the course of that, blood transfusion is needed. And in normal, from my biology knowledge, is then your blood is screened for infections, and then the matching of the blood group. Is that also a consideration, or further examinations are taken before that's done?
That's also an important point you bring about. So currently we receive our blood as a country from the National Blood Transfusion Services that offer screening. So in terms of transfusion-transmitted infections, we know that our blood is screened for that. We know that blood grouping and cross-matching is also done at especially even at hospital. But one of the things that happens in sickle cell disease that needs to be discussed when we are handling blood is, remember, this patient is constantly, a number of them are constantly being transfused. So they are usually minor blood groups that are not usually talked about, but they have an implication on whether the patient's, that blood is able to survive. Now, the problem with that is that we do not do extended typing for this kind of blood, which should be made available for patients with sickle cell disease. But lastly, remember, when we talk about we get blood from the community. So when you have patients who are coming from sickle cell endemic areas, they're probably going to get blood that is found from that community. There's a lot of traits that are in the community that don't show up the disease, but they go on to, you know, to donate. So apart from just the normal typing, TTI testing, we might need to also include sickle cell testing for our blood donors, so that if trait is found, then this is not the kind of blood you want to give to a patient who has sickle cell disease. And
does sickle cell get worse as someone gradually ages?
So the disease gets worse because at this particular point, as you're aging, then you're having a lot of complications. So by the time you're 35, if you probably do not have care, if you were lucky to still live, you've probably have had a stroke, you've probably have had recurrent chest, acute chest syndromes, you've probably had a problem with your heart, you've probably had your kidney affected, even bone probably destroyed. So it gets worse because you then have accrued multiple complications as we proceed with life.
Okay. And does it also affect the life expectancy? Or what is the life expectancy of someone with sickle cell disease? Normal average or?
So we are seeing patients even in our countries who are going past 50, 60. I've treated a patient who's in their 60s, but this is a patient who was incorporated to care. But remember, as you rightfully said at the beginning, if proper care is not given, then under 5 mortality is very high.
How important is it, given acceptability is another pertinent point, for mental health here, given the processes that we have talked about of someone getting that mental counseling, for him to open up to something up to the extent of acceptability?
You're asking very good questions today.
I always
You always do. But mental health is a great pillar in the management of sickle cell disease. And when you look at the SHA package currently, it has a tariff that supports mental health. Now, mental health is important because, number one, there are certain times where even manifestations of the disease could be just managed by psychosocial support, including pain. So we know that these patients are in pain because of the occlusion that takes place, but they could also be psychologically stressed because of the disease.
Okay.
The other people that need to be given a lot of psychosocial support is adolescents, because there's something that now is becoming something that we are really thinking about as healthcare workers, and that is called transitions. Now, remember, when you're a pediatric, you're constantly being brought to the clinic by your mother. You know, your parents are there for you. But as you're transitioning to the adult period, you know, we have a lot of non-adherence during this period of time. And it's because they feel like they are a burden. You know, my mother is not going to work because I'm having a crisis. The other children cannot have normal lives because we don't have money. My mother is always taking care of me. They have issues to do with other children are not taking hydroxyurea. Why am I the only one who is taking? Remember, we've talked about even issues to do with their facial features could change. So even issues to do with esteem. So during this period of time, hydroxyurea is not going to sort out your esteem issue. You need somebody who can sit down with this patient, explain what the disease is, and give them a lot of psychosocial support.
Yeah, and then the other is about the diet of someone with sickle cell. Is it specialized in a way with someone like diabetes? Are there foods that you have to avoid, and be very deliberate on how you take care of what you eat?
Right, so we basically insist on a balanced diet for a patient with sickle cell disease, but we also normally talk about the importance of hydration. So usually a patient with sickle cell disease might need 1.5 times fluids above what is normal. So usually I make a joke when I see patients coming to me in the clinic, and I tell them, I know you're not hydrating, and they'll ask me, how do I know? Because I'm not seeing you with a bottle of water. So they constantly need to be well hydrated, because dehydration does precipitate a crisis. Yeah,
the importance of managing someone's environment.
Very important, and especially we've talked about issues to do with infections, because infections could precipitate, and then also thinking about malaria endemic areas. While we have said that the trait does confer protection against severe malaria, patients who have the disease, because malaria does cause breakdown of red cells, causing anemia. They're already anemic, so you want to do your normal things, have a mosquito net, you know, you have to drain stagnant water, things that we do for malaria. But over and above that, insisting on vaccinations. So there's a vaccination that is provided through our EPIS program, but there's also over and above that kind of vaccination that strategically is given for sickle cell disease.
Yeah, and this includes the environment around watching also your mindset, is it?
Yes, including watching your mind, keeping a very positive attitude. I was talking to some of my patients who would say, you know, I'd tell them, what is your position in school? What are you thinking about university? And they'll tell you, will I be alive to go to the university, for example? So you want to just keep them hopeful, get them to watch and see other people who are living normal lives, becoming professors, actualizing their potential. So mindset does play a role.
Yeah. Is there a limitation around what then someone can do with sickle cell disease, given that some could be willing to engage in sporting activities, going to the gym, doing exercises to keep the body fit? acceptable or not?
So it has to be done within limits, with some limits, because we've said deoxygenation, or rather low oxygen in circulation, does precipitate a crisis. Now, for as much as you'd want them to keep fit, these are not the kind of patients that you tell to go mountain hiking, because, you know, within the mountain areas, the oxygen tension is quite low, or probably scuba diving. So whatever activities are done should be very graded and within certain limits.
Yeah. And in terms of the discovery, are then the clinical attempts made here in our country? That's also another question someone is seeking to seek clarification on. Is that somewhere we are heading with our advancement and putting the effort, putting the money where it's needed? I know I have put in the question about the funding, but are we hurtling towards that progress of advancement, of finding our own way of responding to this, given the huge numbers that we report on?
So currently there are great clinical trials that even are happening within the country that we hope will be giving us good data towards addition of kind of treatment that can also go alongside hydroxyurea. But apart from that, within the country, over and above just participating in global clinical trials, there still needs to and we will be doing it in the World Sickle Cell Day, to move towards funding that establishes a national center of excellence for sickle cell disease. And that is something that we want to put across to the Ministry of Health, that when we think about the next budgets, we need to talk about proper funding towards the establishment of center of excellence.
Yeah, and you're hopeful that will happen?
I am very hopeful. I'm generally a very hopeful person.
And at what level are you cooperating with other actors across the globe, given that it's going to be celebrated across the world, for interchange in one, medical knowledge, technological breakthrough, and the gains in even getting grants to the extent that that can equally be done here? What is your level of contact and collaboration with other partners across the globe?
So the good news is that we have a number of partners that are currently at play with sickle cell disease. We've got support from the Empath group in Eldoret that's doing fantastic in terms of care for sickle cell disease. Apart from that, we are also having international organizations like tomorrow. I know there is a collaboration between sickle cell disease and hemophilia that is getting support from Novo Nordisk Hemophilia Foundation and Foundation Pia Pava, which will be giving support towards capacity building, newborn screening, and a bit on equipping certain facilities, and also awareness about sickle cell, including advocacy for patients with sickle cell disease. So there's a lot of collaboration that is happening. KEMRI is doing great research with sickle cell disease and hydroxyurea. So there are a lot of partners that are on the table, including pharmaceutical companies that are now willing to negotiate and come down on their hydroxyurea dose costs. So there's great collaboration that is happening, but we just need to amplify and bring new partners.
So, and this is all in a way that is working towards the goal, given that you have mentioned KEMRI, which is a critical institution here in our country. And are you hopeful this can equally then take us to that point of the breakthrough, commensurate with the number that we have talked about of the 14,000? And what's needed, because the treatment is a lot. We talked about earlier on, you have mentioned the risk of infection, blood transfusion, and acute transfusions is also another one here that I want some specifics on, and the intermittent transfusions and the difference that you can draw here. What is it then that you can provide an emphasis on here?
Right, so that's also a question that is important to sort of elaborate. So we have acute transfusion in sickle cell disease and what we call chronic top-up transfusions. So acute transfusion would be occurring in patients who are anemic. So for example, a patient comes and they are 2 grams below their normal hemoglobin, then you just do an acute transfusion, acute top-up transfusion for them. Or a patient who's presenting with acute chest syndrome, again, you do a top-up transfusion. So you just want to raise their hemoglobin to the steady state. But then there's something that we call chronic transfusions. This would basically be happening not necessarily just to work on the anemia, but as part of therapy. So patients, for example, who have stroke, who have suffered a stroke in their lives, these are patients who chronically need transfusions probably every month or 6 weeks to just ensure their HB is around 10. Then also pregnant women who have sickle cell disease. Remember, when they are pregnant, we do not give them hydroxyurea. So basically the kind of support that we give them is just chronic transfusion. The other patients who can also benefit from chronic transfusions are, again, patients sometimes who have these leg ulcers that cannot not healing. There might be a role of chronic transfusion. The only problem with that is that, remember, as you give transfusion, then you're raising iron levels. So these patients become iron overloaded. But again, lastly, is just to mention that we have what is called exchange transfusion, which is to bleed out the patient and add more. All right, we have some 2 SMSs, so you can respond to this, Daktari. We'll be pulling that up here on our screens. This coming from our viewers and on the very specific topic that we are discussing here. Yes, thank you, Ibrahim. Jen says, good morning. I'm writing from Sondo in Kisumu County. My daughter was diagnosed with sickle cell disease at just 5 months old. She's now 5 years, and the journey has been incredibly tough. There is little to no awareness of SCD in rural areas, and that lack of information puts many children at risk. Please put the doctor's number. I have a patient, so we'll share with you this, Mike. Rafael Cheruto says, is SCD acquired by a person being exposed to carcinogenic elements, Daktari? Oh, no, not really. This is a kind of mutation that we had said occurs in particular areas, and it doesn't have any particular relation with carcinogenic in that. Your final words here, Daktari? So my final words would be, as we gear towards celebrating World Sickle Cell Day and the kind of advancement that we are excited about, including gene therapy, it is important for us to come together and think about multisectoral support and strengthen what is already standard of care and make it available to as many areas as possible. Newborn screening, accessibility to hydroxyurea, folic acid, antibiotics, vaccines, proper transitions to care, and just to let our viewers know that you can pop in at any of our Equity Afya clinics for any support on sickle cell disease. Dr. Rebecca Mwakichako, many thanks for your time. Much appreciated for laying an emphasis here on this very important subject, and it's a pleasure having you here on the broadcast. The pleasure was all mine. Asante sana. And thanks to you too for waking up with us here on the broadcast. The hashtag on X has been Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. Well, my colleague Sam Gituku was on my earpiece, enjoying me on why I had so distorted a voice this morning here on the broadcast. I wouldn't mention the rest of the sentence that he sent me on my WhatsApp, but would be glad enough if you can grant me a cup of ginger tea. And good morning.